My name is Dr. David William Goodman. I'm an adult psychiatrist who specializes in the treatment of ADHD in adults, specifically older adults and older women. ADHD is attention deficit hyperactivity disorder. This is historically thought of as a childhood disorder with inattention, hyperactivity, and impulsivity. These are behaviors observed by others that are beyond the scope of the normal child. You need to keep that in mind. This is beyond normal, and these symptoms cause impairment. Now, we know that of the children with ADHD, 60 to 90% will continue to have symptoms as an adult, and those symptoms become also impairing in their life as they go through high school, college, first job, marriage, promotion, children, and all of the developmental phases of your life that causes increased responsibility. Again, the inattention, the distractibility, the impulsivity, the restlessness for the adult is similar to the child, and again, is beyond the scope of a normal human experience. It's often confusing when we talk about ADHD because everyone will say, look, I have times when I get distracted, I can't stay on task, I'm procrastinating, I'm losing track of time. But the ADHD individuals have had these symptoms their entire life. The difference between the diagnosis of ADHD in children is that boys are diagnosed more often at a rate of 2 to 1 to girls. Boys are diagnosed often because of their disruptive, impulsive behavior that becomes evident in classrooms to teachers and parents. Girls often don't get diagnosed because they're not disruptive. It doesn't necessarily mean they don't have ADHD. It just means they have ADHD inattentive presentation without the disruptive behavior. As a result, the girls often don't get diagnosed until later in life. In adolescence, they often get diagnosed with anxiety and depression, and the ADHD gets missed. As you get older, the rate of diagnosis of males to females is approximately 1 to 1. And that is, as the girls mature and their difficulties become evident in the environment as inconsistent performance, they then get identified and diagnosed. It's often been said that girls are under-recognized and underdiagnosed for ADHD, which has historically been the case. If we look at recent CDC prescription data, it does show that women over the age of 35 are actually being prescribed stimulant medications that are used for ADHD treatment more often than males. So for girls and adolescents, they're not diagnosed as often, but for middle age and older age women, they're being diagnosed equally, if not more often than males. We know that as the children age, it's not the disruptive behavior that gets you into difficulty. It's the fact that you can't execute consistently, and it's noticed by yourself in higher education, college, or in your first job, or with a partner in a relationship. Remember, cognitive symptoms in the present are not a diagnosis of ADHD. ADHD cognitive symptoms start in childhood or early adolescence, are relatively unchanged over time. So the ADHD individual will say, I've never not been like this. The non-ADHD individual complaining of cognitive symptoms will say, I wasn't this way 6 months ago or a year ago. So the accuracy of making the diagnosis, even being aware to ask questions about its existence, is critical. And the shortcoming heretofore has been ADHD in adulthood is not a focus in professional training programs. That is, whether it's a psychiatric residency, a psychology PhD program, nurse practitioners, social workers, etc. So a lot of clinicians and providers out in the field seeing patients are learning about this in the field. They didn't learn about it in their professional training. As you get older, there's an increased risk for cigarette smoking, increased risk for substance use, increased risk for alcohol, increased use of other illicit drugs, increased criminal behavior. You're more likely to not finish high school. You are more likely to take longer to finish college. You are more likely to be unemployed, in debt, gambling, sexual promiscuity, twice as high to be divorced versus the average adult. And the negative consequences just accumulate over time. If, as an adult, you lose your job every 2 years, you're forever starting in an entry-level position, which means that you're going to generate less than your colleagues and peers in regards to income. And so people with untreated ADHD are always playing catch up and cleaning up their mistakes. Judgment, motivation get compromised. Financial issues are a problem. They miss bills. They're paying late fees. They get into debt. They run up their credit card. So this is not a benign disorder. Now, everyone with ADHD doesn't encounter these things. And if you have a supportive environment, you have a good partner, you've had parents that have been very involved, you have resources that are brought to you, then some of these negative consequences can be mitigated. The approach in treatment for ADHD, we often say, is pills and skills. We know the medications are highly effective. In fact, the medications for ADHD are some of the most effective medications in all of medicine. There are two psychiatric conditions I can treat in an hour or two. One is a severe anxiety disorder with a benzodiazepine, and the other is ADHD with a long-acting stimulant medication. There's a broad range of medications, but medication won't teach you skills. Psychotherapy is used to evaluate a person's attributes and challenges and teach them skills to overcome some of the challenges. So it's very specific for the patient. Is there an issue of time management? Is there an issue of organizing and sequencing a task? Is there difficulty remembering what needs to be done during the course of the day? And so the psychotherapist can set up behavioral routines to teach you new skills. Now, beyond the skill training, there's another element of psychotherapy, and that is learning that ADHD is not something you choose to have. It is something that you have, but it is not who you are. That is, you have a disorder you didn't choose to have, like blurred vision, hypertension, or diabetes. But ADHD is not who you are. The difficulty here is that if you grow up with untreated ADHD and the environment is repetitively critical over the course of years and decades, you come to believe that that's who you are. When you get your ADHD treated, and your symptoms improve and your performance improves and people notice that you're better, you come to realize the difference between what you have, ADHD, versus who you are as a person. That's extremely liberating, and it resurrects people's self-image and gives them a heightened sense of confidence to take on opportunities they previously would have refused to take on for fear of failure. I think the principal focus for the future is education of clinicians seeing patients, whether that clinician is working in the mental health arena or whether that clinician is working in primary care or other medical specialties. We need to introduce a focus in professional training programs on ADHD so that this is not something that's being learned in the field. With the awareness of the public about ADHD driving people to get evaluations, we now encounter a new challenge. This diagnosis is not made by simply checking symptoms in a box. It requires professional training in order to evaluate the accuracy. And so we don't want people diagnosing themselves, getting on medication that they ought not otherwise be on. The difficulty here is the medications we use for ADHD also cause performance enhancement in those people who don't have ADHD. ADHD is a complex set of symptoms that have to be distinguished from symptoms that are associated with anxiety, mood disorders, substance abuse, eating disorder, panic disorder, etc. And so there's a lot of symptom overlap in the diagnostic considerations. all of these are critical concepts because the DEA and the FDA now have become very vigilant about the prescription of stimulant medications as they rise in the population. And we as clinicians want to make sure that people with the disorder are getting appropriate treatment, and those people without disorder are not being prescribed medication they ought not be on. And I think that we are moving towards that. We are certainly moving towards that faster now than we were 20 years ago. I've been in clinical practice for 40 years, so I've seen quite a transformation that I think is very good, but we need to be mindful of staying in the guardrails.